We're moving on to talk now about the thyroid gland, and we'll also talk just a little bit about the parathyroid glands. Again, remember the thyroid gland is located kind of in your neck region. It wraps itself around your trachea, just inferior to your larynx or voice box. And it's important for manufacturing both calcitonin, which helps regulate calcium levels in the blood, and also for releasing thyroid hormone, which is important for metabolic activities in the body. So let's go ahead and look at some different conditions with the thyroid. And again, because we're looking at endocrine glands, the theme is you can either have hypersecretion or you can have hyposecretion. So let's look at what happens when you have hypersecretion of thyroid hormone. This is called hyperthyroidism, also frequently called thyrotoxicosis. And that's what this young man from India had when he came in, presented in an office. You can see that he had so much thyroid hormone present in his blood. It was overstimulating his basal metabolic rate, and no matter how much he ate, he could not put on weight. He had an elevated heart rate. He was probably sweating, very jittery, difficulty sleeping. After being diagnosed with hyperthyroidism and receiving treatment, you can see within a matter of about 5 months later, he looks like a normal, healthy boy again. Now, there are two main groupings of thyrotoxicosis or hyperthyroidism. You can either have a primary hypothyroid condition or a secondary hyperthyroid condition. Primary hyperthyroidism results from some problem specifically occurring with the thyroid gland itself. Secondary hyperthyroidism means that the problem arises elsewhere in the body and it is somehow impacting the function of the thyroid gland as a secondary outcome. So among the examples of primary hyperthyroidism are Graves' disease, which we'll talk about in a minute. But just to remind you, Graves' disease occurs when a person starts making antibodies that mimic TSH, and you'll remember TSH stands for thyroid stimulating hormone. That's a hormone that stimulates the thyroid gland to release thyroid hormone. Another condition is toxic goiter, and toxic goiter is when I have a hypersecretion of thyroid hormone, usually due to some sort of adenoma. And that adenoma could be just one single adenoma somewhere in the thyroid gland. Sometimes it can be multinodular, where there's multiple regions of adenomous tissue. If we look at secondary hyperthyroidism, I'll give you one example. Sometimes the pituitary gland may be the cause of hyperthyroidism. Remember, the pituitary gland makes that TSH hormone. If I had an adenoma in the pituitary gland and I had hypersecretion of TSH, well, then it would follow that I would also subsequently develop hypersecretion of thyroid hormone in response. Now let's look at Graves' disease for just a minute. Again, you'll remember this is an autoimmune disease where we start making antibodies that mimic TSH. So they tend to bind to the TSH receptor on thyroid hormone cells and cause those thyroid cells to release thyroid hormone. Now, don't think that that's the only avenue to developing Graves' disease. There are other types of autoantibodies that a person can manufacture that can also lead to overproduction of TH. Things like sometimes people can develop an antibody called thyroid growth stimulating immunoglobulin. Sometimes people can develop a type of antibody called TSH binding inhibitor immunoglobulin. You don't need to know those. The only one I'm going to ask you to worry about is the TSH autoantibody. But I just want you to be aware that there are other avenues that can ultimately produce the same clinical manifestations. So some of the features that a patient might present with that has Graves' disease, and by the way, Graves' disease is common, relatively common in women compared to men. About 1 to 2% of all women in the U.S. have it. They'll present with, of course, what we call a goiter, which is an enlargement of the thyroid gland in the neck, usually because of both hyperplasia and hypertrophy of the thyroid. And that's just simply a result of getting overstimulated to produce thyroid hormone. They will frequently display dermopathies, which means diseases of the skin, the most common of which is what you see in this picture here. This is called pretibial myxedema. Myxedema means fluid accumulation, and what you're seeing here in these shins is you've got some fluid accumulation in the front of the tibia, and it's causing inflammation, and it almost makes their skin look like orange peel, actually, kind of like orange peel. And they oftentimes will develop, and I'm circling a few here, I don't know how well you can see them. These are called indurations. And an induration is a hardening in a region of tissue that results from repeat bouts of inflammation. You can clearly see there's a lot of fluid accumulation, for example, in the ankles here. They often will present with an eye condition I'm going to show you a picture of on the next page, but we call these ophthalmopathies. Say that 3 times fast. Of course, if I'm producing too much thyroid hormone, I'm going to have weight loss. I might have elevated heart rate. I might have elevated basal metabolic temperature, etc. So here's what a woman looks like that has Graves' disease. She's not intending to look surprised. This is in a relaxed state. There's so much fluid accumulation, edema behind her eyes, it's literally pushing her eyeballs anteriorly, and this is called exophthalmos, or bulging of the eyes. Classic sign of hyperthyroidism. Of course, she's also got that goiter that you would expect to see. You can see she's kind of got this enlargement in her neck region that's indicative of the thyroid gland undergoing hypertrophy and hyperplasia. And then, of course, she's going to present with all those metabolic perturbations I talked about, like elevated heart rate, weight loss, inability to sleep, really jittery. Her reflexes are very jittery, etc. Now, on the other end of the spectrum is hypoparathyroidism. Hypoparathyroidism, just like hyperparathyroidism, can be a primary or secondary cause. Primary means that the problem is with the actual thyroid gland itself. Secondary means that there's some other problem in the body, and as a result, I get the development of issues in the thyroid. So among the primary examples, you can have, sometimes people will develop antibodies that directly attack the thyroid. And as a result, destruction of thyroid gland tissue means you don't have the ability to make sufficient amounts of thyroid hormone anymore. Another option is bacterial infection. This is called thyroiditis. That can destroy thyroid tissue and reduce thyroid hormone output. In regions of the world where nutrition is not good and there is a lack of iodine, I can have what's called endemic goiter. Iodine is an absolutely required element for the manufacture of thyroid hormone. Without iodine, thyroid hormone cannot be made. So in regions of the world with poor diet, poor nutrition, endemic goiter can be a primary hypothyroidism cause. And sometimes certain drugs can actually impact thyroid behavior. Secondary hypothyroidism problems can include congenital ones, which we're really not going to go into much. The one that's more common, I think, is that sometimes people will have hyperthyroidism. Let's say they had an adenoma, and the surgeon goes in and removes that adenoma from the thyroid, and they have to remove so much of the thyroid gland that so little is left that now they have hypothyroidism. Not a huge big deal. You just supplement with thyroid hormone pills, and you're good to go. Now this lady over here shows you what it looks like pre and post treatment for hypothyroidism. You can see when she came in to the doctor, she had really dull faces. Means her face and skin are kind of dull looking. She doesn't look very particularly alert. You can see that she's got looks like weight accumulation, probably because of reduced metabolic activity and weight gain. And you can see post treatment, once they put her on thyroid hormone, her skin looks brighter, her eyes look more alert, she's clearly lost some weight, makes a big difference. And it's a simple fix to treat hypothyroidism with medication. So let me give you just one example of many different types of primary hypothyroidism. Here's one example. Hashimoto disease is an example of primary hypothyroidism. This is an autoimmune disease. And as best as we can tell, Hashimoto disease results when a helper T cell becomes sensitized to the cells of the thyroid. And that helper T cell, that CD4 cell, begins to make clones of itself that are sensitized to thyroid epithelium. And those helper T cells then secrete interferon gamma, and that activates macrophages to begin destroying thyroid cells. That helper T cell, once it's activated, can also then activate CD8 cells, and those CD8 cells will then go out and start directly killing those thyroid gland cells. And that helper T cell can also potentially stimulate a plasma cell to manufacture antibodies that attack or bind to thyroid epithelium. And of course, once that thyroid epithelium is marked for destruction, anything from a macrophage to a natural killer cell can come by then and destroy those cells. Hashimoto disease as a type of autoimmune disease is again more commonly seen in women than men. It usually presents at middle age, somewhere in the 20 to 40s. And women that usually present with Hashimoto will come in with they'll have a little bit of a goiter, a little bit of enlargement of their thyroid, but it's painless. And they might have a little bit of hypothyroidism. So maybe their heart rate's a little low. Maybe they're putting on a little bit of weight, etc. So what are some of the clinical features of hypothyroidism? Well, first of all, let me just say hypothyroidism, if you're born with it because of a non-functional thyroid gland for whatever reason, is called congenital hypothyroidism. Some older textbooks call this cretinism. That's considered a non-politically correct term and is no longer used, or it shouldn't be used, but occasionally people still use it. So just know if you see that, it's the same as congenital hypothyroidism, meaning you're born with a low-functioning or non-functioning thyroid gland. So let's take a look at this little girl here. She had hypothyroidism as a little girl. So she's 10 years old. She's got severe primary hypothyroidism, and when she came into the doctor's office, you can see that she has a good amount of weight gain and fluid accumulation. But look at her after treatment. After treatment with thyroid hormone, she's happy, she's bright, she's lost weight, and although you can't really see it in this picture, she's actually grown in height. According to the information on this, at this point, at 10 years old, before treatment, she had not yet lost a single milk tooth. So, but after she was treated, she lost her teeth. She started to catch up in bone in growth again, and as a result, developed normally from that point forward. Now, if I have hypothyroidism and it appears in an adult, there's a whole collection of symptoms that kind of come together as a suite of characteristics that are fairly diagnostic for hypothyroidism. And collectively, these are called myxedema. And they include things like cold intolerance, meaning that your basal metabolic rate has dropped so low that you're cold all the time and you don't like to be anywhere that's cool. Usually they have a reduced heart rate. They tend to gain weight pretty readily because their basal metabolic rate is low. They tend to accumulate fluid. That's edema. Their gastrointestinal tract is less active, so they develop constipation. They can be listless. They can have slow or sluggish reflexes. And they can even start to get accumulation of fluid in things like the pericardial sac. And of course, once you get an effusion or a collection of fluid in a serous membrane like the pericardium, that's going to put additional pressure on the heart. Heart has to work harder to push against that excess fluid, and you can develop eventually heart failure. Primary hypothyroidism is typically diagnosed by looking at TSH levels. Now remember, TSH is a hormone that's released from the anterior pituitary, and its job is to stimulate the release of thyroid hormone from the thyroid gland. It makes sense that if you want to know if the hypothyroidism is due to a problem with the thyroid gland, it makes sense to go look at the anterior pituitary and ask yourself, are the levels of TSH normal? If the TSH levels are normal, that tells you the anterior pituitary is functioning normally, and whatever issue we've got with hypothyroidism is a direct result of the thyroid gland itself not behaving properly. Now, I want to just briefly talk about the parathyroid glands. Remember, these are located on the posterior side of the thyroid. There's 4 little nodules here. They're very difficult to identify as separate glands from the thyroid. But they contain some cells in them called the chief cells, and the chief cells are responsible for the secretion of parathyroid hormone, and they will release parathyroid hormone anytime there's a drop in calcium levels in the blood. So the job of parathyroid hormone is to stimulate osteoclasts. Those are the cells that break down bone and release calcium into blood to help elevate calcium levels. And they also, remember, inhibit osteoblasts. Those are the cells that tend to build bone. Now, hypoparathyroidism is a really rare condition. People don't often develop this. Usually the only time somebody develops it is if during the process of having surgery on their thyroid, the surgeon accidentally removes the parathyroid glands in the process. And it's, again, as I said, it can be easy to do because it's hard to tell where the thyroid gland ends and the parathyroid glands begin. This is treated just with giving the patient for the rest of their life parathyroid hormone by medication. More common are primary and secondary hyperparathyroidism, where you have overproduction of parathyroid. In fact, primary hyperparathyroidism is one of the most common of the endocrine disorders out there. And it should make sense to you that if I have too much parathyroid hormone being manufactured, I'm going to have overstimulation of those osteoclasts, and I'm going to start losing bone mass. So if we look at a patient with primary hyperparathyroidism, such as we see here, here's a patient. You can look at an x-ray of one of their fingers. And I want you to notice up here at the top, at the tip here, that you can see that there's a loss of bone mass, that after treatment for the hyperparathyroidism, we start to reestablish some bone mass in that area. Usually hyperparathyroidism is due to some sort of cancerous tumor, some sort of adenoma. Typically, it's seen in women more frequently than men, and there's a constellation of symptoms that some medical student, I'm sure, thought they were really cute when they came up with this because it all rhymes. And that constellation of symptoms for hyperparathyroidism is painful bones, renal stones, abdominal groans, and psychic moans. Well, painful bones should be obvious to you. If I'm degrading away bone at a rapid rate, I'm going to start developing stress fractures, micro stress fractures, and of course that can be painful. If I'm degrading away bone, it's going to be causing a huge elevation in calcium levels in the blood, and the kidneys are going to have to start filtering out that excess calcium. And as they do that, they're going to be producing urine that is very saturated with calcium ions, and that can lead to the development of renal stones, or what are also called kidney stones. Now, these last two, abdominal groans and psychic moans, it's not understood. The pathogenesis of the development of these two is not well understood. We just know that it is a common feature that's seen. Abdominal groans includes things like constipation. Person has difficulty digesting food properly. They might have pain with digestion, etc. The psychic moans includes things like they might be lethargic. They might display depression. They might even have seizures. And again, why these abdominal and central nervous system problems result isn't clearly understood. I'll give you very briefly one example of a secondary hyperparathyroidism problem, and that is if my kidneys are failing, if a person has renal failure, that means that the kidney's ability to retain ions is getting lost. So rather than retaining sodium and retaining calcium as it should, the kidneys will just release those ions because the kidneys aren't functioning properly. And so we start to get an accumulation of things like calcium in the urine. And of course, if calcium levels begin to drop in the blood, you're going to start to see parathyroid hormone release increase to try to combat that problem, and then as a result you're going to get that constellation of symptoms we see here. But notice the underlying primary reason we have the problem is not because of the parathyroids misbehaving, it's because the kidneys aren't functioning properly.